Hi, this is Theresa Stratford, and I'm with Dr. Robert Ball with HealthLinks magazine. I'm the managing editor. Dr. Robert Ball is an assistant infectious disease professor at MUSC, and we're going to be talking about, the coronavirus and everything with it. So the first thing I just kind of want to talk to you about is, just to get started, who should be the most worried and the risk factors involved? Who should be the most concerned about this virus?
Concern, yes. Worry, no. Everyone, literally, because this virus is now officially a global pandemic. It's widespread in many communities, and some in clusters, some not. And it's here in South Carolina, in one cluster in Kershaw, but sporadic cases here and there, which will only increase. So the proper precautions we'll talk about in a moment.
Okay.
But be concerned and prepare personal hygiene and stock up on supplies such as canned goods, non-perishables, in case you come in contact with someone and have to be isolated at home for 2 weeks.
Okay, and you're saying, how is it spreading? So you're saying basically make sure you're washing your hands, using the hand sanitizer. Is that the best way to prevent?
That's a preventative or a preventive measure. But how is it spreading? It's airborne.
Yeah.
For example, if I were coughing and didn't cover my cough properly, which means with the elbow, like this, on the inner elbow, our mothers had it only half right. Yes, cover your cough, but not with your hands. Never, never, never with your hands. Okay. So cover your cough. But if I were to cough and not cover, you could be exposed. 6 feet is thought to be the distance for these large respiratory droplets. But it could be more than that, because when you cough, you create a cough cloud. And it may go 10 feet or 12 feet. The large droplets fall down within an hour or two.
Okay.
The smaller ones can linger around for more than that.
Okay, okay. And being worried about travel and the spring breaks that are going on right now, over the next month, really, with colleges, and the kids are going to be out, locally here that first week of April. I mean, is this something that we really need to be concerned about for when they return? And, I see that a lot of colleges are now closing.
Good question. Many schools, from high schools to colleges, have students going on spring break very soon. And if those spring breaks are to countries like Italy, well, that's off, because Italy has now completely closed its borders, and this morning Denmark did the same thing. And you will find this cascade effect, country after country closing its borders. Look at what our president announced last night. No more incoming flights from Europe, the entire continent of Europe, for the next 30 days starting this Friday night. And that's going to cause incredible economic grief and personal grief. And what it means is that kids, especially the young ones who have to stay home during that period of time, are going to drive their mothers nuts.
Yeah, I can understand that. So, and that brings me to the next question. Why aren't children being affected by this?
They are. Children are. The rate of transmission from one infected person to another is the same regardless of if the exposed person were average age, middle age or older, elderly, or even a young one. The young ones can catch it just like the old ones. And the R0, or the infectivity rate, is infected person can infect 2 to 3 or 3.5 others, 3.5. That's an important number, which we'll come back to. That's much, much higher than influenza and other conditions, but not nearly as high as whooping cough or measles or chickenpox, which are much, much higher. They have a much higher infectivity rate. But for this virus, one infected person who coughs can infect 2 to 3 others, maybe 4.
Okay. So, but children aren't seeing the same effects, though, correct?
Well, if you define effects as getting ill, same as middle age and older. If you define effects as complications, now that is different, because older people have more complications. So the older you are, the more likely you are, if you catch this infection, to get a complication, especially if you have an underlying condition such as heart disease or underlying lung disease, if you're a smoker, etc. And so many people in China smoke, hence their high case rate of hospitalization, why they had to build these crash hospitals quickly, and so forth. And there, the risk of complications, including ending up in the ICU, ending up on a ventilator, and eventually dying, increases with age significantly.
Okay.
14% of people over 85 will end up in the hospital in the ICU.
Okay. Oh, okay. And that brings me to another question I had was how would you know, I read somewhere that it's a drier cough and is what coronavirus is compared to a cold or the flu. It's more of a drier cough. Is that correct? I mean, kind of what's the symptoms and what happens to you?
The three major symptoms are cough, fever, shortness of breath.
Okay.
Fourth is fatigue. But those same symptoms apply to influenza, which is much more prevalent than coronavirus at this point. And those same symptoms can be found with dozens of other viral and some bacterial infections. So clinically, even good clinicians can't completely diagnose somebody based on symptoms. It requires symptoms, a good physical exam, and maybe some testing. And there are 3 stages or steps in that testing that we can talk about.
Okay. As the weather gets warmer, that's something that people have talked about. Will it die? I mean, is that something?
Good question.
Yeah.
There are scientific experts around the world who feel like this virus is going to be with us for the rest of this year, regardless of the hemisphere or season. Recall that it started in the northern hemisphere, our summer, and Wuhan in Hubei province, China, is generally the same latitude as parts of the United States. It started in the winter. It was a coronavirus, like so many other dozens and dozens of coronavirus families, a reservoir in bats, and somehow in November got transmitted to people because bats are actually a source of protein food in poor countries. And in that open market, bats were displayed as food. Not live bats, but dead bats. And so it's thought that the virus mutated, was transmitted that way to people, and then person to person to person in its mutation. It learned to develop a new trick. That's a definition of an emerging infectious disease. A brand new bug like this one, or an old bug like staph that learns a new trick like antibiotic resistance. And this is a relatively new bug with a new trick. And even since then, and China publicized this to the world at the end of December, and a week later shared the genomic sequence with the medical community globally, and developed a test for it and realized it had an outbreak. Even then, most governments, including ours, were slow to respond, slow to develop tests. Actually, Europe and a few other countries were far ahead of the U.S. in developing tests, number one, and in mass producing them, number two. And that's been the biggest problem, is that we don't have enough tests in America because our administration thought that this would just simply blow over and go away by the summer. Somebody in Washington had a hunch.
Okay. All right. And if it did dissipate soon, could it come back next summer? I mean, next winter,
It will never dissipate completely.
No.
What we may see are waxing and waning. It may, for example, it's waxing now in these months, but it's also confounded by the fact we have much more influenza. So you pile that on top, and now in the northern hemisphere we're getting into pollen season. Not hay fever, because hay fever is a misnomer. There's no fever with that, but allergy season. Very hard to distinguish those, and we'll talk about that because that is mostly an upper respiratory, whereas coronavirus is mostly deep down in the lungs and body-wise.
Okay. Yeah. All right. Yeah. So, I guess let's talk about that. Some of the differences, I guess, with allergies, cold and flu, and this virus. I suffer from seasonal allergies, so this is normal for me. But I mean, how will I know if it's something worse?
And you know what your own symptoms are from
Yeah.
seasonal allergies.
Yes.
I have them too. Most
Yes.
people do.
Sure.
And when you develop bad stuffy nose, sneezing, and it doesn't go much below the throat,
Okay.
and you get a little bit of a sore throat due to postnasal drip, you know that to be seasonal allergy. If you get those same symptoms and they turn into a cough and maybe a little bit of fever, then you may have one of the dozens of winter cold viruses. If you have a high fever, severe body aches, myalgia as we call them, and many other symptoms, including intestinal symptoms, that may be influenza. Because influenza is not only respiratory, it's total body and intestinal.
Right. Okay.
Unlikely to be this coronavirus for now, but in a few months, as the proportion of cases in the United States based on the population rapidly increases, this is not going to be a straight line arithmetic curve. This is going to be an exponential curve going north very quickly over the next few months. And only by testing, proper testing, can we distinguish the coronavirus, or SARS, severe acute respiratory syndrome 2. We call this the son of SARS. Only by specific testing can you distinguish that from influenza and the other respiratory viruses, which includes simple coronaviruses, which cause 1/4 of common colds.
Okay. Well, could there be a vaccine created that could make this go away?
Yes.
Right.
And in fact, Congress, as you know, has just appropriated, and President Trump signed, an $8.3 billion relief package to the CDC that he had underfunded for several years, and to the National Institutes of Health to do research on both vaccines and several medications which can block the virus.
Okay.
Very much like the HIV medicines block HIV, antivirals we call them. They're not antibiotics. We think of antibiotics like penicillin and the mycins and so forth, amoxicillin, ampicillin. Those are antibiotics, but the interesting thing is that antibiotics means anti-life, antibiosis. So antibiotics we park over here for the bacteria. Antivirals are for viruses, and for HIV we have over 40. And interestingly, a couple of those seem to have some effect against this particular virus. And that's what the National Institute of Health is studying, several of the HIV cousins, if you will, against this. They're also working with one major and two other companies in a very hurry-up fashion to develop and test vaccines, first on mice, and if it seems to generate an antibody immune response, then they will test it on a small group of people and make sure they don't have any serious side effects, and to see if it works. So you're looking at safety and efficacy.
Takes time.
Safety and efficacy. Is it safe? Yes, the side effects are minimal. Is it efficacious? Does it work? That's going to be the thing.
Okay, and that will take a long time to figure out, right?
It will take months. The estimate from Dr. Fauci at NIH, who is the country's top scientist in this regard and spokesperson, except that he has been sort of muzzled by the administration a bit, he estimates that we'll have a vaccine, or should have a vaccine, scalable to large percent of the population by the end of this year.
Okay.
We're all hoping and praying it'll be sooner.
Sure. Yeah. Okay. So let's see. Talk about the strain. You said there's all these different strains. So coronavirus, there's a worse strain and then a lower strain. So okay.
Good question. There are dozens of members of the coronavirus family, dozens. And when you look at their genetic makeup, most of the ones that cause the common cold are very similar. The ones that cause SARS, severe acute respiratory syndrome, in 2002-03, very different lineage, if you will, a different branch of the family tree. The one that later caused MERS, Middle Eastern Respiratory Syndrome, that is resident in camels carry that one, not bats, camels, which are unpleasant animals. But Camels carry that one, which is why Saudi Arabia has the highest concentration of the MERS cases there. But it's a coronavirus. It's a different branch of the family tree. This one, SARS-2, or son of SARS, is very severe because it has a high transmission rate, and it also has a high mortality rate. And that mortality rate currently is about 3.5% of the known cases. Now, this is not identical to the case fatality rate, which is a medical term used once the epidemic or pandemic in this case is over. The mortality rate, which is the denominator being confirmed cases around the world, which at this present time, I think the figures from this morning were 140-something thousand known confirmed cases around the world, with hot spots in China, Italy, now Europe, etc. That's a denominator. The numerator are those people who are confirmed and who die. So you just do the simple math, and it's a 3.5% mortality rate currently. But what we don't know is the denominator. Those are the confirmed cases. But here's the flip side of that. 80% of people who get this infection, just like West Nile virus and AIDS, HIV, etc., 80% of the people don't know they have it because they have either no symptoms or mild symptoms. That's the base of a pyramid. Imagine a large pyramid. And what we're seeing right now is just the tip of the pyramid is the known cases, and the very, very tip are the deaths. But the question before all of us is, okay, when is medical science going to know how big the base is? We estimate right now, based on SARS experience and modeling with this one, that about 80% of the general population will have caught this virus and either don't know it or have a mild illness that they brush off for a few days and recover. The downside of that is they're infectious to others, even with a mild illness, and even worse, they're infectious about a day, maybe two, prior to their very, very first symptom, if they get a symptom. So that's the medical difficulty that we in academia and clinical medicine face, is determining that base of the pyramid. And we can only do that by developing a blood test, an antibody test, to see if anybody has antibodies to this specific virus. And the National Institutes of Health is working with the CDC diligently to try to develop an antibody test so we can go around and draw blood samples from thousands of people around various parts of the country to see if we have large percent or a small percent of the population. West Nile virus, it's estimated 80% of the U.S. population has had it, but don't know they had it. And think of that analogy to this.
Wow. Okay, so the next question is avoiding crowds, you know, everything that's going on with the public right now, the way colleges are closing, events being canceled. You know, I mean, is this the best way to help, you know, keep the spread from going? I mean, it's hard because, you know, life is kind of halting.
Good question.
In a way.
Good question.
Yeah.
It's what to do about travel. We've addressed that, and yes, spring break travel to Washington, D.C., probably not a good idea. They don't have a huge cluster there, but they've got small clusters in parts of D.C. Seattle, Washington, with that nursing home in the town outside of Seattle, big cluster there. But we have these little clusters, and the Johns Hopkins University website is probably the best place for very, very up-to-date information. That's JHU, Johns Hopkins University.edu. Then you click on the coronavirus link, and it'll eventually surf you around to this map that they update every few hours. It gives you, in the middle, a global picture by continent and by red circles for the numbers of cases in those areas. Started off with Wuhan, was bright red, and then the entire Hubei province, and then all of China, and then Italy, and then Iran, and then South Korea and Japan. You get the picture.
Yes, okay. So events, yes, we should probably try to avoid larger events. I mean, right now.
Large crowds, indoor crowds, with the 6-foot distance that the CDC recommends. And that's a 6-foot distance, not just from people in general, but anybody who is ill with a cough, sneeze, sniffles, whatever. Because you don't know which to use a colloquial term, which couldy they have.
True.
They could have common cold, they could have influenza, or they could have this.
Okay.
And as coronavirus becomes more prevalent, that's going to become part of the general mix. So try to keep a 6-foot distance. And if somebody's coughing, number one, they shouldn't be in a crowd. They should absolutely go home, whether it's an adult or child. And this is why we are concerned about kids, because kids are great couldy carriers.
Yes, they are, yeah.
And kids don't know much about hand washing, which is so important, because people still shake hands, and don't they? And people still cough into their hands. It's an old habit. In the South particularly, the genteel South, we shake hands routinely without thinking about it. And handshaking has to absolutely come to a halt, and use elbow bumps, bump elbows, or a fist bump, or the peace sign, or whatever, or some sort of sign that you acknowledge your neighbor and honor and respect that person without infecting them.
All right, and you know, compared to other viruses, I was reading about the H1N1 in 2009. That lasted about a year. Over 12,000 people died. 61 million people were affected, but it did end up going away. Not completely.
It never went away.
Never did.
It did what most epidemics, in this case pandemic, around the world. It hit hard, and then the curve went down, but it never went to zero. And those cases have continued because that virus has mutated a little bit year after year after year, tiny bit, and it is still included in the annual influenza vaccine all around the world. Year after year after year since 2009. That's simply the year that it hit really hard and then went down, but not away. There's a big difference. So if you look at the vaccine recommendations, again put out by the CDC for this quote year or season, although influenza is 24/7, 365 every day. We just don't test for it during the summer months because it drops down during the summer months for various reasons. But if you look at that virus, it never went away. It's still in the vaccine mix.
So that could happen with this, just kind of always.
Eventually with the vaccine mix. The scary thing about this virus is that the strain that came out of China is still the dominant strain. But there is a second strain that is a mutation of a mutation. And it's going around now too. 20 to 30% of the global cases are strain 2 of SARS-2, or the son of SARS.
And are we on our way to getting more of these kits? I mean, I saw now that MUSC is doing the drive-through testing, so obviously
drive-through screening first, and then testing. Yes, but they have to, at the moment, go through the MUSC website here in Charleston for that registry number. You just can't drive up and sit in your car and expect to be swabbed.
No.
By the way, the swab is a very long swab that goes all the way back into the nose. All the way back, not just a tickle in the front of the nose, goes all the way back. And it makes the healthcare provider who's taking the swab cough and sneeze on. So we have to have the healthcare providers wear mask, eye protection, and gloves and gowns. Because if I put that long swab way back in your nose toward the base of your brain, basically, then you're going to sneeze, cough, and not like me very much.
Yeah, definitely. Oh Lord,
And then that goes to the testing. So what are those swabs? What do those swabs test for? They go into a media, a little test tube of viral transport media. They go in together, mix it up, and you've got a lot of viral particles of whatever you have. You may have 2 or 3 different viruses, but usually just one dominant one. And that gets the rapid flu test, which you can get a result back in an hour. So some people choose to go park their car or go shopping or whatever. Maybe not a great idea, but the point is you can get the rapid flu test results quickly. If it's positive, bingo, you've got a hit. You go home, take Tamiflu, and after your fever goes away for 2 to 3 days and you're on 5 days of Tamiflu, then you're good to go.
Okay.
But if that rapid flu test is negative, and if it's negative, it's a flip of the coin, 50-50. And that has to do with not taking the test properly, which is why MUSC has set up these tents with special personnel, trained personnel, and exhaust negative airflow, if you will, to properly take the test. But if that's negative, then the rest of that mix goes to check for various respiratory viruses, which include the simple coronaviruses that cause the common cold.
Okay.
Now, in a few weeks, MUSC is also going to have the coronavirus test.
Okay.
But right now, in South Carolina, like in most states, the State Public Health Laboratory is the one who does the coronavirus testing. And in South Carolina, 100 per day.
Okay.
And they have enough kits of the right kind, because there was some confusion about that early on too. So that's the 3-step testing. Flu first,
Okay.
various respiratory viruses, and by the way, that test costs about $200 or more, and insurance covers it generally, or people can self-pay, or MUSC will hopefully get part of that $8.3 billion.
Okay.
Even though President Trump asked for 2.5, there was bipartisan, near unanimous support that public health needs a lot more.
Okay.
Public health has been underfunded forever,
Yeah.
and the public gets as much help as it pays for. It's as simple as that.
Okay.
So that second level test, $200. The coronavirus test, about $800, which is why it has to be restricted to people who really, really need it. The worried well, no, you will not get a test just because you're worried. You will not get a test, period.
Okay.
If you have very, very mild symptoms and you don't meet certain benchmarks on the list, then you're recommended to stay home and take your temperature, monitor, and not go out in public, because whichever cootie you have, you can still pass it on.
Contagious, right?
But if you're moderate to severely ill, then yes, you can go through that testing. Private doctors cannot simply write an order for Joe and John and Jane to go through this drive-in. It's a little more complicated than that at the moment.
Okay.
Hopefully, though, in a few weeks when we get more test kits, and here, like in most states, then we'll be able to do more drive-in testing and swabbing.
Okay. Okay. Well, you said at the beginning, I said, who should be the most concerned, the most worried? You said concerned but not worried. So what, I guess we can conclude with that statement. You know, what do you mean sort of by that?
Okay. Concerned meaning you pay attention to the news.
Okay.
Because most of the news is pretty accurate. Well, there are a few little wrinkles in that on, but most of it is pretty accurate. Various websites, the CNN, the New York Times, keep up to date. The Johns Hopkins website keeps up to date.
Okay.
Various medical websites, musc.edu here in the Low Country.
Right.
Great website for information. The DHEC website, Department of Health and Environmental Control here, is a good source, but generally they repeat what the CDC has just put out.
Sure. Okay.
So, but it's a good website too. And then of course you have cdc.gov.
Okay. Okay. All right. Well, is there anything else that you wanted to say? I mean, anything we haven't covered? You think you got it?
Folks, just be sure to wash your hands a lot, and quit shaking hands. That's probably the most unwise public health practice around nowadays. And cover your cough or sneeze with the inside of your elbow. Greet somebody with the outside of your elbow. And if you're sick, Lordy, stay home. Don't go to work. Don't send your kids to school. Don't expose others, because remember, you have not only your health and that of your immediate family to worry about, you have the community to worry about. And if you're not concerned about the community and don't care about the community, then okay, spread all the goodies you want.
Okay. Well, thank you very much for talking to us. Let's just do that. Yeah. All right. Thank you guys. Appreciate it.